I'm Dr. Molly Douglas. This month's Skillz meeting is on neurocognitive rehabilitation for ACL reconstructions. We are going to talk about how integrating the brain into ACL recovery can enhance traditional ACL rehabilitation. I want to start with two discussion questions. First, how would you define neurocognitive rehabilitation in the context of ACL injury recovery? And what do you think it might include that goes beyond traditional strength and range of motion exercises? Secondly, in your experience, how well do standard ACL rehabilitation protocols prepare patients for the unpredictable nature of sports? And what gaps or limitations do you see that might be addressed by incorporating more neurocognitive elements into rehab? Before we dive in, let's ground ourselves in where we're headed today. First, we'll define neurocognitive rehabilitation, what it is, how it differs from traditional strength and neuromuscular work, and why it has become indispensable after an ACL injury. Next, we'll examine the neurophysiological changes that follow an ACL tear. We'll look at cortical remapping, proprioceptive decay, and the executive function impairment that can linger long after the graft is strong. Third, we'll move from theory to practice, demonstrating neurocognitive exercises and logical progressions you can integrate into your treatment sessions tomorrow for early, mid, and late phase rehab. Finally, we'll discuss return to competition criteria using evidence-based outcomes. By the end of this session, you'll have a clear blueprint for treating the knee and training the brain, so your athletes return not just stronger, but smarter and safer. Now you may be asking, what is neurocognitive rehab? Well, it is a therapeutic approach that deliberately couples cognitive processing tasks such as attention, perception, memory, reaction time, and decision-making with sensorimotor and functional movement training. By challenging the brain and the body at the same time, it leverages neuroplasticity. This allows us to remap proprioceptive input and motor output that was disrupted by the injury or surgery. It reconstructs efficient feed-forward and feedback motor strategies, restoring dynamic joint stability and movement quality, and it embeds cognitive load into sport-specific tasks, so patients can execute rapid, accurate decisions under the unpredictable conditions they will face on the field or court. So why does this all matter? Surveillance data from U.S. high school athletics shows a 26% rise in ACL tears over the last 15 years, with girls soccer and basketball leading the surge. Similar upticks are documented worldwide, and the average injured athlete is getting younger. So in short, we're seeing more ACL reconstructions, and we're seeing them sooner. Reconstruction is not the finish line. Depending on the cohort you study, 13 to 25% of patients will experience a second ACL injury. For athletes under 25 who return to pivoting sports, that jumps to roughly 1 in 4. Those numbers are telling us passing strength and hop tests does not guarantee a safe return to play. So why is re-injury so prevalent? We now know that the ACL reshapes the brain as much as the knee. Visual spatial memory, reaction speed, and divided attention tasks all suffer. Functional MRIs and EEG studies show heightened frontal parietal activation, meaning patients rely on conscious, visually driven control rather than automatic proprioceptive control. The result is slower decisions, stiffer landings, and higher knee valgus moments when the sport becomes chaotic. Neurocognitive rehabilitation targets that missing link by pairing movement with cognitive load, counting back drills during single leg stance, color cue cutting drills, reactive perturbations. We harness neuroplasticity to remap afferent and efferent pathways, rebuild automatic joint stability, and lessen dependence on visual over control. In other words, we train the brain and the knee together under the same split-second pressures that caused the original injury. The skyrocketing incidence of ACL tears and the stubborn re-tear statistics demand more than quad sets and hop tests. Neurocognitive rehab acknowledges the central nervous system changes after the injury and uses them to our advantage, reducing re-injury risk and delivering athletes back to sport with the mental and motor tools they actually need. To understand why our rehab strategies must go beyond muscle and joint, we have to appreciate what happens inside the central nervous system the moment an ACL tears. Immediately after the injury, the brain enters a highly plastic state. Functional MRI studies show reduced activity in the primary motor cortex and heightened recruitment of the secondary visual spatial areas. This means the patient shifts from automatic proprioceptive-driven control to a more conscious, visually guided strategy. That plastic window is both a risk, because maladaptive patterns can stick, and an opportunity if we load it with the right sensory motor challenges. When the ACL's mechanical receptors are ruptured, afferent proprioceptive input to the spinal cord and cortex drops sharply. On the efferent side, quadricep activation becomes delayed and hamstring co-contraction unreliable, leading to a feed-forward control deficit. The result is slower reflex stabilization and a greater chance of valgus collapse on landing and cutting. Effective rehab must therefore recreate high-quality afferent stimuli, think perturbations, joint position matching, and force plate feedback, while retraining rapid efferent drive. Because sensory feedback is degraded, the athlete must devote more cortical resources to basic knee control. That extra cognitive load leaves fewer attentional reserve for sport-specific tasks like scanning the field or reading opponents. Dual task studies show consistent, slower reaction times and riskier biomechanics in post-ACL athletes compared to healthy peers. Our takeaway: integrate cognitive tasks, color cue cutting drills, reactive light landings, so the athlete relearns how to move efficiently without blowing their cognitive budget. In short, ACL injuries rewire the brain, sever critical feedback loops, and taxes attention. A neurocognitive rehab framework directly addresses these challenges, turning neuroplasticity from a liability into a performance advantage as we guide the athlete back to sport. With these neurophysiological shifts in mind, let's turn to the core principles that harness them in neurocognitive rehab. Now that we have a basic understanding of the brain-based changes that occur after an ACL injury, let's discuss the guiding principles that turn that science into day-to-day clinical practice. Integrate early and progress gradually. Introduce light cognitive load, basic counting, color matching, simple reaction cues, and this can start day one with having the patient perform a quad set in a long sit position while reacting to blaze pods on the desk in front of them. From there, escalate complexity in parallel with tissue healing and strength gains. Dual task everything, because sport is never single task. Pair every strength or balance drill with cognitive demand, such as arithmetic during step downs, Stroop cues during single leg stance, decision-based cone cuts during shuttle runs. Specificity and unpredictability. Mimic the athlete's sport, position, and most common injury scenarios. Layer in randomness, visual flashes, coach commands, opponent shadows, so that feed-forward control is challenged under real-world chaos. Variability with repeatability. Rotate drills frequently to prevent skill stagnation, yet revisit core movement patterns enough to reinforce efficient neuromotor maps. Psychologically informed. Blend confidence-building exposure, graded imagery, and autonomy supportive coaching to lift ACL RSI scores alongside physical metrics. And then lastly, leverage visual perturbation and distraction. Deliberately overload the visual system. Flash react boards, strobe glasses, and moving backgrounds so that the athlete relearns to trust proprioceptive input when vision is noisy or delayed. Progress from slow, predictable flashes to rapid, randomized stimuli that force quick reweighting of sensory information. Applied together, these principles thread anatomy, motor control, vision, and confidence into a resilient, game-ready athlete, making neurocognitive work the backbone of the modern ACL rehabilitation.